Approach to a patient in emergency medicine department. When a patient arrives in the emergency medicine department, they don't arrive with a diagnosis, they arrive with fear and undifferentiated conditions. And in that moment, there is no time to open textbooks and often no time to search for the guidelines and no time to wait for the investigations as well. You must have a system, a framework, a way of thinking that allows you to rapidly identify life threats, prioritize interventions, and make critical decisions with whatever the incomplete information that you have with you. That framework is what we are going to discuss it today. Welcome to Dopamine and Decisions. This channel is dedicated to the emergency medicine resident and physicians, but this video lecture helps people who are interns, NEET PG aspirants, and duty doctors, and other critical care trainees or physicians, and anyone who is interested in the science behind decision making in the emergency care. This lecture is a first in a complete emergency medicine foundation series that is based on the Rosen's emergency medicine textbook and the Tintinelli's emergency medicine textbooks. Over the upcoming videos, we'll cover every major aspect of the emergency medicine. But before we actually discussing about individual diseases and conditions, we need to understand how to approach every patient who walks into the emergency medicine department. Because in emergency medicine, your approach comes before your diagnosis. And if your approach is wrong, obviously that is going to harm the patient. With this introduction, let's go and begin with what are the things that we are going to see in this video lecture. Learning objectives. Before we actually start, here is what I want to take away from this video lecture. We have each section highlighting each of these objectives. I'm not going to waste time regarding this. But remember one thing, that emergency medicine isn't about memorizing hundreds of the diseases. It is about developing a reliable system that works every single time. Part one of our discussion is the emergency medicine department. What is emergency medicine actually? The definition that is given by the Tintinelli's emergency medicine is that it is the immediate recognition, stabilization, evaluation, treatment, and the disposition of a patient with acute illness and or the injury. Notice that what we are talking here is that the definition starts with the recognition. It is not actually the diagnosis. You need to actually recognize the emergency. People don't die because you fail to diagnose them. They die because we fail to recognize any airway obstructions, shock, sepsis, or myocardial infarction or stroke. Okay, because time is the tissue, and that's why emergency medicine is built around only one fundamental question, is that is the patient going to die now? Okay, if the answer to this question is yes, you need to treat them immediately before you are actually going for the diagnosis of these patients. Another important concept is parallel processing. Unlike other specialties where assessment is followed by the treatment, in emergency department, these both happen simultaneously. While investigations are being sent, oxygen is being started. While you're taking IV cannula, you are actually going to do the airway assessment. Having said this, I want you to understand that this parallel resuscitation will happen only if you have a team of work. If you're not having a team, you need to actually go into the vertical resuscitation. That is only A, B, C, D, and E. Okay. Assessment and resuscitation must happen together. The emergency physician is the one who takes high-stake decisions with incomplete information in a timely pressure environment. This is the defining skill of every emergency medicine doctor. Triage. Every patient who arrives in the emergency medicine department cannot be seen at the same time. That is the reason why we developed triage. Triage is not about you are diagnosing the patient, it is about identifying who cannot safely wait. Most patients use a structured triage system, such as the Manchester triage system, which categorizes patients based on their urgency. During mass casualty, use the star triage or as the star triage. These help in prioritizing the limited resources that we have. But regardless of the system you use, remember that the principle remains same. That is, the treat the sickest patient first, not the patient who arrives first. Okay. One important point to remember is that triage is a dynamic thing. A stable patient that is now can deteriorate while waiting. This is the reason why a reassessment is just as important as the initial triage decision. With this thing, let's discuss about these triage systems for a brief second, and then we move on to the next slide. So what is Manchester triage system? This is the most widely used internationally. Okay, so here we have red and orange categories, which who needs our immediate attention. Out of them, red are the most dangerous one, who needs our immediate attention. That is, immediately we need to jump onto them. These are the cardiac arrest patients who are having apnea, who are unresponsive, systolic blood pressure that is less than 70, and the major hemorrhage patients. Next is that orange, who are very urgent. These need to be addressed within 10 minutes. These are patients who are with chest pain, stroke, severe dyspnea, GCS that is less than 14, and the sepsis. Yellow are the one who needs to be attended at least within 1 hour. These are the moderate pain patients, stable fractures, and fever with rigors and the vomits. Green are the standard ones who need to be attended at least within 2 hours. These are the minor lacerations, UTI, mild pain, and the stable vitus patients. Blue are the one need to be attended at least within 240 minutes, that is 4 hours. These are the patients who are with chronic conditions and who came for a prescription refill. Okay. Star triage. Here, we are not going to bother about these green and the black patients. Green patients are patients who can safely walk away without any complaint. Black patients are the one who cannot breathe even after airway reposition. We are not going to waste time on both of them. Red are red red are our priority one. Who patients Which patients comes under red are patients who are tachypneic, that is breathing more than 30 per minute, or patients who are not having any radial pulse, patients who cannot follow simple commands. Okay, patients who comes under yellow are patients whose respiratory rate is less than 30, but it would be more than 20. Patients whose pulse is present, but it can be feeble. Patients who actually obey the commands. Okay, what is SALT? In SALT, we have SORT, assess, life saving, do the life saving hemorrhagic control, or else any intervention, life saving intervention. Last T is the treatment or the transposition. Okay. Part two of our discussion is approach to the trauma patient. Now that we have discussed the general mindset of an emergency physician, let's move on to one of the most structured scenarios in the emergency medicine, that is the trauma patient. Trauma is different from the most medical emergencies because the mechanism of injuries often tells us where to look before actually symptoms appear. Most important, trauma patients can deteriorate within minutes. This is the reason why we don't examine them very randomly. We follow a standardized approach, and worldwide that framework is given by the ATLS, that is Advanced Trauma Life Support. ATLS primary survey. The primary survey is the foundation of the trauma resuscitation. Its purpose is simple: identify and treat immediately life-threatening problems before moving on to the next step. Remember, one principle throughout the trauma management is that treat threats as you find them. Don't finish the entire ABCDE before intervening. If you identify a life-threatening airway obstruction, you fix it immediately before actually going for the breathing. Or else, if you recognize a tension pneumothorax during the breathing assessment, decompress the chest immediately. Assessment and treatment always must happen together. Let's briefly go through each and every component. First is airway. Airway comes with the C-span control or C-span motion restriction. Here you need to ask only one question: is the patient able to speak clearly? If the patient is able to speak clearly, it means his airway is patent. Look for any secretions like blood in the oral cavity. If there is something such like that, do the oral section. Always do the jaw thrust. Do not prefer doing the head tilt because you're already suspecting there is a cervical spine fracture, so you don't want it to be aggravated. Use OPA or NPA if the patient is obtunded. Avoid NPA in case of if you're suspecting any base of the skull trauma fracture. If the patient's GCS is less than 8, go for the rapid sequence intubation. Prefer going through the video laryngoscopy. Go for the surgical airway if it is a cannot intubate, cannot oxygenate kind of condition. Next is the breathing. Breathing comes with the ventilation. Always start every trauma patient with 15 liters of oxygen via the non-rebreathable mask. Here, you need to assess for the chest rest symmetry, look for the tracheal position, and do the percussion of the chest. Okay, look for what is the respiratory rate, saturations. If you are identifying any tension pneumothorax in any patient, immediately go and do the needle decompression. Do the chest three-side chest seal if you are finding any open pneumothorax. Keep chest drain if you find any open pneumothorax or pneumothorax or else any hemothorax. Okay, circulation comes with the hemorrhagic control. Wherever you identify hemorrhage, immediately apply direct pressure. If needed, apply tourniquet as well. If you're suspecting any pelvic fractures, apply pelvic binder. Uh, any trauma patient, a patient in whom you are suspecting any hemorrhage, take two large IV bore cannulas. Start resuscitating the patient with crystalloids. That is followed by the blood. Okay, why blood in trauma? Because you're actually losing the blood. You need to replace the blood that you have actually lost. Okay, here you need to assess for the skin color, temperature, and the moisture, and look for heart rate, BP, and the capillary refill time. If the patient is appearing pale and cold and clammy, then suspect shock without any monitor as well. Okay. In disability, we are assessing the neurological status of the patient. Here we have three components: GCS, pupillary size, and one most important thing is important and most reversible condition is the blood glucose, that is hypoglycemia. Correct hypoglycemia as soon as you find it, because it takes minutes to reverse it. If you are suspecting any traumatic brain injury, the clue which you can have is the systolic blood pressure that is more than 90 mmHg and saturation more than or equal to 95 percentage. Okay. If if you are suspecting any traumatic brain injury, consider paging for the neurosurgery. Next is E. E for the exposure. During the exposure, you need to fully undress the patient front and back. Do the log roll with the C-span control and make sure that you are not missing any injuries. Okay, remember this E exposure is also tagged with the environment. While you're undressing the patient, you're actually making the patient to expose to the external environment. And during this time, patient is at the risk of hypothermia. Risk of hypothermia. What this hypothermia causes in trauma patients is that it triggers something called as lethal triad. Please tell me what is lethal triad. If your answer is hypothermia, acidosis, and coagulopathy, then you are right. Coagulopathy. This is a lethal triad. You must make sure that you must do all your efforts in order to not trigger any of this one, because triggering any of this one will trigger the others. That is why this is called as lethal triad in trauma. Okay. What will you do if the patient is developing hypothermia? Give the patient warm blankets, infuse warm IV fluids, and during the exposure, document all the injuries. At the end, don't forget doing the rectal or the perineal examination. One mistake many junior doctors makes is treating ABCDE like a checklist. Actually, it isn't. It is a continuous cycle. Every intervention should be followed by the reassessment. If the patient condition changes, you must start again from the A. For suppose a patient is having hypotension and the patient is having hypertension and the patient is having reduced blood sounds on the right side. Okay, this is actually the tension pneumothorax. So you do the needle decompression and keep an ICD. So basically you are relieving the tension pneumothorax. After that, instead of going for the circulation, what you need to do is that you need to actually come back, start doing it from the airways. Look for how is the patient. Look if is the patient able to speak clearly or not. Okay, so this is the thing. Once you do the intervention, you need to always reassess, and that reassessment has to again start from the A. This is the dictum of the ATLS. Next is the hemorrhagic shock. Let's spend a minute on the hemorrhagic shock because it remains one of the leading causes of the preventable trauma deaths. Recent ATLS guidelines has shifted away from the estimated blood loss in liters. Instead, we focus on the patient's physiology. Look at the trend. How is the heart rate? How is the BP? Is the BP falling? Is the patient becoming confused? Is the base deficit of the patient responding? Oh, sorry, worsening? Are they responding to the resuscitation? These physiological markers are much more reliable than trying to estimate for the blood loss at the bedside. Another key principle is this: a normal blood pressure does not exclude significant hemorrhage. Young patients can compensate. For that matter, even young patients and pregnant female can compensate well until they suddenly decompensate. Always look at the whole patient, not just the monitor. With this thing, let's walk through this slide. This hemorrhagic shock is divided into four subgroups. Minor, that's subgroup 1, minor subgroup 2. This is also called as minor to moderate, and moderate and the major one. Okay. Here, while I'm walking through it, I'm going to make a box for the things which need to be remembered very easily. Okay. In minor subgroup 1, when it comes to the heart rate would be unchanged. Here minor subgroup 2 also am I unchanged to increased, whereas in moderate it would be increased that would be more than or equal to 100. In major it would be increased that would be more than or equal to 120. Okay, systolic blood pressure would be unchanged in the minor one, but it would be unchanged to decreased, and it is markedly decreased, that is less than 90 mmHg in case of major hemorrhagic shock. When it comes to the pulse pressure, it would be start decreasing at the minor subgroup 2, and respiratory rate would be unchanged to increase in the minor subgroup 2, but it would be definitely increased in case of moderate hemorrhagic shock. When it comes to the level of consciousness, it would be decreased in the moderate hemorrhagic severity. Base deficit would be normal in case of minor subgroup 1. It starts decreasing from the it starts worsening from the minor to moderate subgroup. Okay, blood products are unlikely to be used in the minor one, but it would be more likely to be used in the moderate group. And massive transfusion protocol is the one that we initiate for during the major. Response to resuscitation, it would be rapid and sustained in case of minor group, but it would be only the transient in case of the moderate hemorrhagic severity. What is transient is that for a brief period, you will find that for your resuscitation, you will find that your patient is actually responding to the fluid resuscitation, but over a period of time, he'll again go into the hypotension. This is the transient response to the fluid resuscitation. And operative hemorrhagic control is unlikely to be in the minor subgroup 1. It can be possibly if it is possibly in case of a minor to moderate, and it is more likely in case of moderate and extremely likely in case of the major one. Secondary survey. Once life-threatening conditions have addressed and patient is stable, then we move to the secondary survey. This is your detailed head-to-toe examination only after the primary stabilization. Before examining the patient, obtain ample history in case of trauma patient and sample history in case of non-trauma patients. Assess for the signs and symptoms. Rest all are same for both trauma and non-trauma patients. And remember the mnemonic, it is the ample. What is A? A for the allergies, M is for the medications. Look particularly for any anticoagulants that he is on, and P is for past medical or surgical history. L is for the last meal to assess for the aspiration risk. E is for the events and the environment of the injuries. Okay. In P, if it is female, ask for the past menstrual history as well. With this thing, let's go and see what is the head-to-toe examination. In head and face, what you need to see are the first and foremost are the scalp lacerations. Once this is done, go and look for the skull base of the skull fractures. What are these? These are the battle signs, raccoon and CSF leak and hemotympanum. All these are the signs of the base of the skull fracture. As soon as you identify any of them, do not NPA is contraindicated. Nasopharyngeal airway is contraindicated. Remember this thing. Okay, and in the neck, what you need to see is the tracheal deviation, jugular venous distension, and C-spine tenderness. Look for any carotid bruise and the penetrating wounds. In the chest, what you need to look for the paradoxical movement, that is the flail segment, and look for any subcutaneous emphysema. Once you are having subcutaneous emphysema, obviously there would be underlying pneumothorax or as the tension pneumothorax. Look for any rib tenderness for the rib fractures and muffled heart sounds for the cardiac tamponade. In the abdomen, what you need to see is for look for any distension for the blood that is pulled up. Look for any guarding or rigidity, that is the signs of the peritonitis because of the blood. Look for seatbelt injury because with that you need to identify any large intestine and small intestine injuries. Hematuria on the urinalysis, it means bladder is ruptured. Actually, FAST is done in the during the primary survey that is in the circulation. It takes just 3 minutes in order to diagnose hemoperitonea immediately. If it is not done in the primary survey, you need to do it in the secondary survey while examining the abdomen. Next is the pelvis. In pelvis, do the single gentle compression for the instability. As soon as you find the instability, immediately apply the pelvic binder. Look for any urethral bleed because that will tell you the bladder rupture. Look for any scrotal or the labial hematoma and look for the rectal tone as well. Okay. And in the extremities, look for any deformities that will tell you the fractures. Look for any open fractures. Look for the vascular status. Assess pulses. And with ultrasound, look for the Doppler as well. See for the any compartment signs, syndrome signs. When you are assessing the spine or a subbrach, you need to go for the log roll by the 4% technique by controlling the C-spine. Okay, and look for any posterior wounds. Remember, without looking for the log roll, your secondary survey is not finished, and primary survey is also not finished in the E. Next is how you are assessing the fracture is the spinal column step off kind of movement and neurological level at the site of the injury. And please do not rush. Missed injuries often occurs because clinicians focus only on the obvious injuries. A patient with an open tibial fracture may also have a cervical spine injury or else an intra-abdominal bleed as well. Next is the eFAST. This is one of the most valuable bedside investigation in trauma. Think of the eFAST as an extension of your physical examination. It allows you to rapidly identify free fluid in the abdomen. It takes just within 5 minutes, hardly takes 1 to 5 minutes in order for you to diagnose the things. Okay, look for the pericardial effusion, look for the abdomen, look for hemothorax and pneumothorax, and everything can be done within few minutes. The most important point is knowing when to act on the result. Okay, if a trauma patient is hemodynamically unstable and positive fast, please shift him to the operating room immediately. Do not take this unstable patient to the seat. eFAST is extended focused assessment of sonography in trauma. Previously, we used to do only fast, that is the four window of the abdomen. With that, we added bilateral lung views. With that, it is called as eFAST or as the extended one. Okay. Why the lung fields are added? Because it is used to detect the pneumothorax and the hemothorax at the bedside immediately before we're actually going for the X-ray. So here things are arranged in an order. Do not think that this is the only order that you need to do. Here, this is placed in such a way that, okay, the immediate life-threatening one can be identified immediately. Or else you can actually start from the lungs and go down as well. There is nothing wrong in doing that. Okay, so first one is the pericardial view. In pericardial view, you need to actually place the probe on the subxiphoid area. So here what you're going to see is that this one, this is the heart that is being shown over here, right atria, right ventricle, left atria, and left ventricle that is being shown over here. So basically what we are looking here you need to look for the pericardial effusion or the cardiac tamponade. How you would see it over here, if there is pericardial effusion, you would see it like this. Okay, heart would be pushed over here, and you would be see the darkish color fluid that is being shown on the white color over here. Next one is the right upper quadrant. Here you need to get this exact view definitely. That is this diaphragm, this lung, and liver and the kidney. This is exact view that you need to get during the right upper quadrant examination. This is also called as Morrison's purge. Here, basically, you are looking for the hemoperitoneum. Next, when you place the same thing on the left side posteriorly, because spleen is placed somewhat posteriorly, so then it is called as splenorenal recess. Okay, here also you need to look for the diaphragm and the lung area, and then you need to look for the spleen, and then you need to look for the left side of the kidney. Okay, if there is any fluid collection over here, it would be seen over here like this. Okay, if there is any fluid collection over here, it would be seen over like this. Next is the pelvis. In pelvis, you look for the bladder injury. So this is the bladder. Here you could able to clearly have erased the ink. Here you could able to clearly see the walls of the bladder. If there is any bladder rupture, you won't be able to see the clear walls of the bladder, and you can find that there is pockets of fluids in case of the bladder rupture as well. Okay. Next is the lungs. During the lungs, what we see is the batwing sign. What is batwing sign? Ribs on both the sides and rib shadows, and this is the pleura. This whitish layer is the pleura. Okay, I'm erasing my ink. So this whitish layer is the pleura. Okay, so this is the bat wing sign. There is bat over here in the middle, and these are the wings. Okay, that is the bat wing sign. Okay, and next, when it comes to the investigations priority, immediate ones are the fast one: blood glucose levels, ECG, saturations, and the EtCO2. Bloods need to be sent within 1 hour are the full blood count, coagulation profile, GNS, ABG, lactates, and the beta HCG. Pan CT need to be done only if the patient is stable. Okay, Pan CT is done only if the patient is stable. Here you need to go from top to down: brain, C spine, chest, abdomen, and the pelvis. So let's summarize the trauma approach. Every trauma patient begins with A, B, C, D, E. Assessment and treatment occur simultaneously. Control catastrophic bleeding early. Reassess after every intervention. Use the secondary survey only after the primary survey is complete and the patient is absolutely stable. And use eFAST as an extension to your clinical examination, not as a replacement for a clinical judgment. So this finishes off our discussion on the trauma. Now, approach to the non-trauma patient. Trauma patients have the advantage of a well-defined ATLS framework, whereas medical emergencies are different. Patients with chest pain, breathlessness, fever, abdominal pain, altered sensorium, or shock rarely present with an obvious diagnosis. Instead, they present with the symptoms. And your job is to rapidly identify who is critically ill, stabilize them as early as possible, and then narrow the differential diagnosis. The key is having a systemic approach. Sick versus not sick, the first 30-second assessment. Before actually taking a history, before actually examining a patient, simply look at them. Within the first 30 seconds, you should be asking yourself one question. Does this patient really sick? Okay. Experienced emergency physicians often develop this instinct over years of practice, but it really based on recognizing the patterns. Look at the patient posture. Are they sitting comfortably? And look at the patient color. How is he? Is he paler or cyanosed or jaundiced or gray skin? Is the patient is having labored breathing and using accessory muscles? Is the patient is sweating heavily? Is the patient normal or else agitated or is the decreased responsiveness? If the patient is agitated, it would be mostly because of the reduced oxygen that is supplied to the brain. If there is decreased responsiveness, there can be a number of problems. But one differential diagnosis which we can keep in our mind is the CO2 narcosis. Patients who cannot complete a full sentence without stopping, this can be due to their breathlessness, or else this can be due to the incomplete perforation, or else patients maybe are there in the altered sensorium. Patient is having staring gaze or fixed eyes looking at the ceiling, can be which is implying absent seizures. They have never looked like this is the line that the relatives are coming and telling you. Always remember that if your gut says that the patient is sick despite the monitor is showing normal parameters, trust yourself. If you think that this patient is going to bad, act on it immediately. Do not let normal triage category or as your previous negative workshop override their clinical impression of a deteriorating patient. One classical example of this is that if any patient with epigastric pain has come to you previously, now don't think that this epigastric pain can be the gastritis itself like it is before. Think that as a myocardial infarction this time and order investigations accordingly. And then opposite to them, the reassuring futures. And a useful habit is to ask yourself, if I let this patient alone for the next 30 minutes, would they still be okay? If the answer is no, or even maybe, then give your immediate attention. Structured approach to the non-trauma patients. Once you have identified whether the patient is sick or not, follow the same structured approach every time. The first step is the vital signs. As soon as you receive the patient, connect him to the monitor. It will give you all the parameters that it is necessary for you. For suppose heart rate, BP, respiratory rate, saturations, temperature, and blood glucose levels need to be checked. And all these forms the patient's physiological footprint. Okay, abnormal vital signs often point out towards the diagnosis before the history does. Next, perform a rapid ABCDE screen even if the patient doesn't have any trauma. Go for the airway, breathing, circulation, disability, and exposure. And this must be assessed. ABCD isn't just only for the trauma, it is a universal approach to any critically ill patient, be it in the emergency or else in ICU, in OT, wherever the patient gets sick, you must always follow this ABCDE screening only. What you are going to see in the airway? In the airway, you see if the patient is able to speak normally or if he is able to speak in full sentences. In breathing, you look for the respiratory rate, saturation, breath sounds, and the chest rise. In circulation, you look for the heart rate, BP, capillary fill time, and the skin. In disability, you look for the ABPU scale or as the GCS, pupils at the blood glucose levels. In exposure, you look for the fever, rash, and the trauma. Once life-threatening problems has been identified during the primary survey and excluded or treated, then move on to the focused history. Here you use the Socrates for the symptom analysis where appropriate and always ask yourself if there are any red flags that suggest a catastrophic diagnosis. Then perform a targeted physical examination. Examine the most likely system, but don't develop any tunnel vision. For example, a patient with chest pain may need a cardiovascular examination, but don't forget to examine the lungs, abdomen, and the peripheral circulation when indicated. Investigations. One common mistake among doctors is that ordering every investigation before thinking. Instead, investigations should answer your clinical question. It should not happen the otherwise. It is not that you treat the patient based on the investigations. You form some differential diagnosis, and to rule out them, you need to order the investigations. Okay. Start with the bedside test for suppose an ECG, blood glucose, pulse oximeter, and point of care ultrasound. These can immediately change the management. Then move on to the laboratory tests and imaging based on the differential diagnosis. Reassessment. Perhaps the most overlooked step in the emergency medicine is the reassessment. The patient condition can change rapidly while they are waiting for the blood results or imaging. Every intervention deserves a reassessment. Improvement confirms that you are moving in the right direction. Failure to improve tells you that you need to rethink the diagnosis and the management as well. Next step is the disposition. Finally, every patient needs a plan. By the end of your assessment, you should know whether the patient requires admission, and if yes, at which level, or observation, or transfer to a higher center, or is safe for the discharge. And if you are discharging a patient, remember that discharge isn't simply sending them home, it's ensuring they understand the diagnosis, the treatment plan, the warning signs to watch for, and when to return to the emergency department. Good safety netting is as important as making the correct diagnosis. Let's summarize the approach to the non-trauma patient. Start by deciding whether the patient is sick or not. Obtain a full set of vitals as soon as the patient comes to you. Perform a rapid ABCD assessment. Take a focused history by the sample mnemonic. Perform a targeted examination. Order investigations that answers a clinical question that you have. Reassess after every intervention, and finally make a clear disposition plan with appropriate safety net advice. If you follow this sequence consistently, you'll reduce cognitive errors, identify critically ill patients earlier, and develop a structured approach that works across almost every medical emergency. Section 4 is common emergency presentations. So far, we have discussed how to approach a patient. Now let's apply that framework to some of the most common and most dangerous presentations you will encounter in the emergency department. These are the patients that every emergency physician sees almost in every shift, like patient in shock, patient in acute breathlessness, patient with chest pain, and patient with the altered sensorium. The key is not memorizing the endless differential diagnosis. The key is recognizing the life threats first. First is approach to shock. Shock is one of the true emergencies in the medicine. The simple way to think about the shock is inadequate tissue perfusion, leading to the cellular hypoxia. Remember, shock is not defined by the low blood pressure. A patient can be in the compensated shock with a completely normal blood pressure. So don't wait for the hypotension to occur before you go into the resuscitation. And there are four main types of shock, and identifying which one you're dealing with guides your treatment. Hypovolemic shock is usually due to the blood loss or else the fluid loss. Hemorrhagic shock is a type of the hypovolemic shock. The priority is to stop the loss and the restore the circulating volume. Cardiogenic shock results from the pump failure, that is the heart, commonly occur after an acute myocardial infarction. Remember, patient with acute myocardial infarction with cardiogenic shock must be immediately taken to the PCI for STEMI. Okay, there is no other way that you should think in these patients. Patient with the acute MI with cardiogenic shock, immediately shift the patient to the PCI. Okay, other causes are also there, like malignant arrhythmia. If it is there, treat the arrhythmia. If it is a cardiomyopathy, you cannot do anything for it. The only thing which you can do is keeping the patient on the inotropes. And if there is acute valvular failure, you need to actually replace it. Take the patient for the surgery, and for the time being, you can give the diuretics for this patient, and diuretics can be given for the heart failure patients as well. These patients need careful fluid management. Next one is the distributive shock. One common thing that we most commonly encounter is the sepsis ones, that is the septic shock, where there would be the profound vasodilatation. Here, you need to give the early antibiotics. You need to start on the fluid resuscitation and source control and vasopressors. Vasopressors are the cornerstone of the management. Other types of distributive shock are anaphylactic shock. Anaphylactic shock is treated with the adrenaline, and neurogenic shock is treated with the steroids. Finally, the one is the obstructive shock. Obstructive shock is caused by the tension pneumothorax or as cardiac tamponade or as a massive pulmonary embolism. And in asthma patient, due to the autopsy, for tension pneumothorax, you do the needle decompression, and for cardiac tamponade, you do the pericardiocentesis. And for pulmonary embolism, if it is massive and if it is causing the hemodynamic instability, that is the obstructive shock, then you must go and do the thrombolysis in these patients. Now, how can you differentiate between each of them is that in hypovolemic shock, JVP would be reduced, whereas in distributive shock, it can be normal. Okay, and in cardiogenic shock, it would be increased, and in obstructive shock also it would be increased. The universal shock management protocol is that to take two large IV bore cannula, start the patient on the oxygen because of the increased metabolic oxygen demand. Continuously monitor the patient, look for the ECG, saturations, and the non-invasive blood pressure. Give fluid challenge, and see if the patient is actually responding or not. If the patient is not actually responding, you need to go and start the vasopressors or the inotropes according to the type of shock that the patient is. Okay, the key thing that need to be done in the shock is that identify and treat the cause. Okay, shock type guides you the definitive treatment. eFAST can helps you in diagnosing the type of shock. Approach to dyspnea patient. Breathlessness is another symptom that demands rapid assessment. Before thinking about the diagnosis, ask two questions. Can this patient actually protect the airway? And are they tiring? A patient who is exhausted, unable to complete full sentences, or developing altered mental status is at the risk of the respiratory failure. Okay, this slide introduces the AAAA framework, which helps organizing the differential diagnosis. Starts with the airway. Could there be an obstruction from the anaphylaxis or from a foreign body aspiration or any upper airway swelling? Next, think about the breathing. Here, you look for any asthma, COPD, or else any pneumonia or LRTI. And most important one is the pneumothorax or hemothorax or massive pleural effusion. Recent one is the ARDS or the COVID-19. In circulation, remember that not all breathlessness are originating from the lungs. Acute pulmonary edema, pulmonary embolism, or cardiac tamponade can all present primarily with the dyspnea. Finally, consider other causes like metabolic acidosis, like in case of focus small breathing, in DKA, in case of severe anemia, psychogenic or the panic attack, in neuromuscular disorders like GBS and the myasthenia gravis, diaphragmatic paralysis, and in pregnancy, either it can be physiological or else it can be due to pulmonary embolism. What is the immediate management that you need to do for the acute dyspnea patient is that start the patients on the oxygen, titrate saturations according to the patient condition. If it is normal patient, you target for the 94 to 98 percentage of saturation SpO2. If it is a COPD patient, you target for the 88 to 92 percentage. Never blindly give high flow oxygen in case of a chronic hypercapnia patient because the patient brain is sustaining because of this hypercapnia. You give excess of oxygen and you take out all the oxygen, all the carbon dioxide that is there in the brain, then it will kill the patient. Okay, remember this thing while dealing with the COPD patients. Next is if the patient is not tolerating or if the patient saturations are not improving with oxygen, you can start the patients on the NIV, that is either BiPAP or is the CPAP for the acute pulmonary edema and acute exacerbation of the COPD. If it is acute exacerbation of the COPD, you can actually try giving the nebulized bronchodilators, diuretics in case of the acute pulmonary edema, and antibiotics in case of the pneumonia. What helps in differentiating our diagnosis is the ECG, bedside echo, chest X-ray, ABG, and the BNP. BNP is usually used for prognosis. It is not actually used for the diagnosis of the condition. And simultaneously with the treatment, you need to actually sending for or do these investigations, not actually stopping the treatment. Approach to the chest pain. Chest pain is one of the most common reasons for visiting the emergency department. But before considering the common causes, always exclude the danger ones. There are five life-threatening diagnoses that every emergency physician must be considered in any patient that is presenting to the ED with the chest pain. First one is the acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, and esophageal rupture that is called as Bohr-Haff syndrome. Okay, each has a subtle difference in the presentation, but all require the urgent recognition and the management. One investigation should become almost automatic is the ECG. Every patient with suspected cardiac chest pain should have an ECG within 10 minutes of the arrival. And a normal ECG does not always rule out the ACS. If you are strongly suspecting the patient is having ACS, you must do the serial ECGs and send for high sensitive troponin at 0, 1, and 3 hours is mandatory before actually sending the patient off at home. Okay, and never thrombolize if you are suspecting the dissection. And now let's go through the each of these conditions and then see. In case of acute coronary syndrome or a STEMI, onset of pain would be the either gradual or a sudden, and it must be increasing with the exertion, and it is not relieving with the rest. Okay, aortic dissection will come with sudden, that is maximal light onset, and it would be uh, radiating to the back. Pulmonary embolism would be sudden, and the pleuritic one, it would be sharp and worse on the breathing. Pneumothorax would be sudden and it usually would be a unilateral if it is on the one side, and it would be sharp and the unilateral. Okay. Characteristic of the pain in the acute coronary syndrome, it will be considered as the pressure type of pain or as the squeezing type of pain, and it radiates to the arm or jaw or the epigastric region. Rest all we have discussed already. BP would be normal or low. In aortic dissection, there would be BP would be unequal in both the arms. At least there would be more than 20 mmHg of difference between the both the arms. In pulmonary embolism, it can be normal or is low. If the patient is pulmonary embolism, BP is low, you must immediately do the thrombolysis in these patients. Next is in case of pneumothorax, it can be normal in case of a spontaneous one. If it is tension one, patient BP would be falling down. ECG would be showing the ST elevation or depression or as the T wave inversions in case of the ACS. In case of aortic dissection, it would be normal or as non-specific one. In pulmonary embolism, sinus tachycardia would be there. Any patient with pulmonary embolism will comes to you with the tachycardia and tachypnea with the SOB. Okay, tachycardia, tachypnea, and SOB that is unexplained, or as if the patient is having major surgery before few days, or as if the patient is long bedridden, then immediately suspect a pulmonary embolism in those patients. One classical ECG patterns that you look in case of pulmonary embolism is S1Q3 T3 and right bundle branch block. In case of pneumothorax, it will be sinus tachycardia, or as if it is not that great, then it can be the normal as well. Key test in case of each and everything is for ACS, it would be ECG and high sensitive troponin serial monitoring, that is 0, 1, and 3 hours. Aortic dissection would be the CT iotogram, and do not thrombolyze these patients except CT iotogram. There is no other test that will diagnose the aortic dissection. Pulmonary embolism, CT pulmonary angiogram, and the ventilation perfusion scan. Always remember that CT is the investigation of choice. D dimer is the screening test. D dimer is the screening test. Always remember CT is the investigation of choice and D dimer is the screening test. 2D echo findings were also being guiding you that the patient may be having the pulmonary embolism. Next is in pneumothorax, chest X-ray is the one that will diagnose, and lung ultrasound in which there is absent lung sliding. Absent lung sliding merely doesn't confirm the pneumothorax. Absent lung sliding must be coinciding with the lung point. Okay, only if you find the lung point, then only you must consider it as like a tension or pneumothorax or as tension pneumothorax. If you don't find the absent lung sliding with the absent lung point, then you don't consider it as a pneumothorax. Treatment would be monoheparin and the primary PCI. In case of aortic dissection, IV beta blockers is the first thing that you need to give before actually shifting the patient to the OT. Surgical repair is inevitable in these patients. Pulmonary embolism, either anticoagulants if the patient's BP is stable. If the patient's BP is low, you need to thrombolyze the patient. And if there are any contraindications for the thrombolysis, you need to actually do the mechanical thrombectomy. Next is the pneumothorax. If it is tension, you need to do the needle decompression, and then you need to drain the air that is there inside by keeping the ICD. Approach to the altered sensorium. Altered mental status is not a diagnosis, it is a symptom with a broad differential diagnosis. The first priority is always the same, always protect the airway. A patient with a GCS of 8 or less is generally unable to protect their airway and should be evaluated for definitive airway management. To remember the common causes, use the mnemonic AEIOU and the tips. These are the common causes of the altered sensorium. What is A is for the alcohol or as the acid-base disturbances. This is the metabolic acidosis. E is for the epilepsy or else the encephalopathy. It can be hepatic encephalopathy or Wernicke's encephalopathy or uremic encephalopathy, or else it can be metabolic encephalopathy as well. Insulin, either hypo or hyperglycemia, opiates or toxins overdose, uremia, and the other metabolic causes. T is for the trauma, like traumatic brain injury, that is the extradural or subdural or the diffuse axonal injury. I is for the infections, that is the meningitis, encephalitis, and the sepsis. Okay, and psychiatric or postictal or as the psychosis. S is for the stroke, either it can be hemorrhagic or as the ischemic. Structural would be space occupying lesions or the hydrocephalus. Okay, and what is the immediate management? Please do not ever forget checking glucose in case of altered mental status patients, because hypoglycemia is the common reversible cause of the coma. It takes just 2 minutes to check and 30 seconds to treat. How you are going to treat these patients? DEFG is the mnemonic. Give dextrose if the blood glucose levels is less than 70. How you are going to do it is that 50 ml of 50% dextrose IV. Never give glucose if before thiamine in case of alcoholics. If it is due to eclampsia, any female of the reproductive age, consider doing the beta HCG. If it is pregnant and fitting for eclampsia, give MGS for 4 grams IV over 15 minutes. Consider giving flumazenil in case of the benzodiazepine overdose is suspected, that is 0.2 mg IV. Caution, take care if the patient is on the benzodiazepines on long-term use for the seizure control, then giving flumazenil will make the patients susceptible for the seizures, and then patients may go into the withdrawal states as well. And give thiamine in case of alcoholic patients and the malnutrition is suspected, 100 mg thiamine before actually giving the glucose. This prevents the Wernicke's encephalopathy. These are the four presentations, that is shock, dyspnea, chest pain, and the altered sensorium. These represent some of the high risk complaints you will encounter in the emergency department. Although the symptoms differ, the approach should remarkably consistent. It must always be A, B, C, D, and E. Okay, recognize the critically ill patients early, stabilize the airway, breathing, and circulation as early as possible. Identify life-threatening diagnosis first and begin treatment without any unnecessary delay. And continue reassessing the patient's response. If you consistently apply this structured approach, you will not only make better diagnosis, you will also make safer clinical decisions under the pressure. Resuscitation, disposition, and safety netting. By this stage, we have assessed the patient, identified life-threatening conditions, and initiated treatment. But emergency medicine doesn't end with the resuscitation. Every patient must eventually reach out one of the four destinations, that is admission, observation, discharge, or transfer. The challenge is knowing when you have done enough for the patient and when it's still unsafe to stop. With this, let's start discussing the last part of our discussion. Resuscitation endpoints. How do you know it's working? One of the biggest mistakes doctors make is assuming that resuscitation ends once fluids or the medications has been given, but it doesn't. Resuscitation ends when tissue perfusion has been restored. So how do we know our patient is improving? Look for the objective markers. Has the heart rate improved? Has the heart rate has come down? Is the blood pressure adequate for the patient's condition? Is the urine output reaching out to the desired levels? Is the lactate clearance is achieving or else is it normalizing? Remember that lactate clearance of more than or equal to 10% is associated with improved survival. Is the base deficit is actually improving? Sorry, this is not greater than, this is less than. Okay, and capillary refill time is less than 2 seconds. Remember that improving skin color and warmth is one of the earliest sign of the response. There is something called as SCV-O2. We'll discuss it when we are discussing about the oxygen cascade and oxygen delivery devices. For right now, what you need to remember is that if it is more than or equal to 70 or 75%, it means there is no increased oxygen demand at the tissue level. So this is used in the septic shock resuscitation in the surviving sepsis guidelines. And triad of death, or as the lethal triad we have discussed earlier. Remember that a patient whose blood pressure has normalized, but the patient is still confused, oliguric, or has rising lactates is not fully resuscitated. Treat the patient, not the numbers. Disposition and safety netting. The last 10 minutes in the ED. Disposition is one of the most important decisions you will make in the emergency medicine department. Every patient should leave the ED with a clear plan. Ask yourself these four questions. Can this patient be safely discharged? Do they need a hospital admission? Would a period of observation help clarify the diagnosis? Or do they require to transfer to the center with a higher level capacity? If you are admitting the patient, ensuring that he is going to the right place, and which patients we are going to admit. These patients are hemodynamic instability or high risk vitals on repeat. If there is ongoing resuscitation that is required for the patient, and high risk diagnosis like NSTEMI, pulmonary embolism, stroke, and sepsis, surgical or procedural interventions are required. Whom do we observe? If the diagnosis is uncertain, need further workup over the hours. For suppose any patient with chest pain, we need to do the serial tropi or as high sensitive tropi at regular intervals. For short procedure like reduction, foreign body removal, and laceration repair, for drug reactions or overdosing that is needing 4 to 6 hours of the monitoring. Here, you do the ED observation or the CDU observation, and disposition decision must be taken within the 24 hours. When do you discharge the patient? Patient who is having stable vitals on the repeated assessment and he's safe to mobilize. Diagnosis is established and initial treatment has been completed. And follow-up is arranged with GP within 48 hours or else OPD within 72 hours. Patients who understand the condition and written instructions are given. Remember, it is not the oral instructions that you need to give or whatever the safety net information that you want the patient to know. Everything must be documented. Okay, written safety net is mandatory. Documenting notes. In India, we are seeing the rise of these medical legal issues because of this. So just to save yourself, make sure everything that is required for the patient to come back immediately must be documented on the note. Next is the transfer. When you transfer, when your resource is not available at your center, for suppose burn center, you need to refer some patients to the burn center, spinal and cardiac cath labs, and neurosurgery or NICU. Make sure you stabilize as much as possible before you actually initiate the transfer. And wherever you are transferring the patient, please call the physician there overhead and explain it to him like whatever is happened at your center. Red flag symptoms, never miss these in the emergency department. Emergency medicine is largely about recognizing the few dangerous conditions hiding among many common presentations. That's why every emergency physician should have a mental list of these red flags. A sudden thunderclap headaches makes you think of the subarachnoid hemorrhage. Chest pain with unequal BP on the arms should make you suspicion of the aortic dissection. Patients who are presenting to you with pulseless, cold, painful limb are the cases of the acute arterial occlusion. Patients with edema, itching, and hypotension must trigger you for the anaphylaxis, where you need to give adrenaline 0.5 mg IM the intramuscularly at the anterolateral part of the thigh. Patients who are with severe back pain with hypotension, please don't forget this thing, that is ruptured abdominal aortic aneurysm. Patients who are with fever and altered sensorium and with petechiae raises the suspicion of the bacterial meningitis. Patients with monocular painless vision loss should suspect you for the CRAO or the retinal detachment. Patients with stridor and facial swelling should trigger you for the angioedema or airway compromise. Give adrenaline IV. Please try to intubate these patients as soon as possible. Patients with scrotal pain and absent cremasteric reflex should suspect you for the testicular torsion. This is a surgical emergency. Need urology or as the general surgery referral immediately. Post head injury and GCS deterioration should suspect you for the extradural or as the subdural hematoma. CT brain urgently and page for the neurosurgery. Now. Now let's quickly test the framework we have built today. A 25-year-old male after RTA with GCS of 14 and BP of 80/50 has heart rate of 132 with rigid abdomen. Fast examination shows there is a fluid in the Morrison's pouch. Best step. See here the BP is low, that means the patient is unstable and heart rate is more than 120. It comes into the major group of the hemorrhagic shock. Okay, so here what we need to do, we need to take up the patient immediately for the emergency laparotomy. CT abdomen is contraindicated because of the patient instability. 2 liters of crystalloid, then reassess can be done, but not in this scenario. And diagnostic peritoneal lavage is not indicated nowadays because you have done eFAST and the diagnosis is already known. Next, a 24 years old female found unconscious and GCS of 7 with pinpoint pupils and respiratory rate of 7 and diaphoresis. Most urgent intervention after airway. See here, female founding unconscious, GCS is low. Pinpoint pupils and respiratory rate is low. Here you should suspect opioid overdose. Here you should suspect opioid overdose. So after you have managed the airway, what is the next best step is that check for the blood glucose levels and the naloxone, which is not one of the 4 recognized classes of the shock. Hypovolemic, neurogenic, hypoxic, cardiogenic. Hypoxic is the answer. What are the 4 types of shocks? Hypovolemic, cardiogenic, obstructive, and distributive. Okay. Next question. A 55 years old male patient presented to you with chest pain, BP with a BP of 170/50 on the left arm and 135/70 on the right arm. Most likely diagnosis is the right answer, that is the aortic dissection. Okay. There is more than 20 mm of difference between both the arms that gives us the diagnosis of the aortic dissection with tearing pain was there. Go for the CT iodogram. Thrombolytics are, again, I'm telling you, those are the contraindicated and that will kill the patient. Before we finish, let's summarize the entire approach of any patient. Every patient who enters the emergency medicine department should pass through the same mental framework. First is the triage. Triage and identify who is critically ill. If it's trauma, follow the ABCD protocol, and that is the primary survey followed by the secondary survey. Only if the patient is stable. If it's a medical emergency, begin with the vitals, ABCD screening, focused history, that is Socrates, targeted examination, investigations, reassess, and the dispose. When managing shock, classify the type of shock before actually deciding on the treatment. And throughout the patient's journey, remember the reassessment. Finally, every patient must leave the department with a clear disposition plan. Having a consistent framework reduces cognitive errors, improve your teamwork, and most importantly, improve the patient's outcome. So that concludes our discussion. I would like to leave you with one final thought. Emergency medicine is not about knowing every diagnosis, it's about making the right decision at the right time. With the limited information you have, you won't always have all the investigations, you won't always have the perfect history from the patient as well. But if you approach every patient systematically, recognize the life-threatening conditions early, and reassess continuously, you'll make safer decisions and become a better emergency physician or the doctor. Remember the sequence, always recognize, stabilize, think, reassess, and disposition. Lastly, thank you. If you found this session helpful, please consider sharing it with your colleagues. Next lecture will be on the airway. Until then, remember one principle that defines emergency medicine is that do not treat the monitor, treat the patient. Thank you for watching, and I'll see you in the next video.